The link will be given soon. Today's lecture is on topic approach to diabetic food. It is taken by Dr. Felix Jebasingh. Sir is currently an associate professor in the Department of Christian Medical College, Vellore. He has authored multiple articles of about 50 articles in international and national journals. He has also authored around 13 chapters in various endocrine books. Sir is also the editor for the book Endocrinology, which is a case-based compendium. Sir has special interest in pathogens of diabetes and offloading diabetic food, as well as prevention of lifestyle related. So for today's topic, this is a one-hour lecture series. Following which, if any doubts, if you have anyone of you have doubts, please put up in the chat box. You can ask directly to sir, and then if any doubts, they also can approach him. This lecture site soon will be mentioned in the website, which will be soon uploaded in our Department of Medicine YouTube website. Now over to sir for the lecture. Thanks.
So, shall I start? Yeah. So, thank you, Anju, for the introduction. And before I start, I'll just have a word of prayer and let's start. Heavenly Father, thank you for this wonderful evening you have given us here to be in this program, Lord. As we discuss about this topic, be with us and enrich us with the knowledge. In Jesus' name we pray. Amen. So this is when you look at this topic, many of us think that this is a highly and surgical oriented topic, but many times this is not a surgical oriented topic. It's actually a family medicine topic, or I would say that an internal medicine topic too, because a lot of patients do come to us with diabetes and its complication, and one of the complication is actually diabetic neuropathy, and which is subsequently a complication of that. Okay, so many of us don't know that one of the highly insured part of the human body is actually a feet. And I'm not going to ask what is this, whose feet is this, but it's none other than Charlie Chaplin. He has actually insured his foot because that's how he has regarded the foot as. So this is one of the patient who I saw just day before yesterday in the OPD, and I thought this is the commonest thing we all see now in our day-to-day practice: a fissure in a feet, and many of us also has fissures in the feet, and by and large we may not do much of this, but how this is a problematic, we'll try to answer this in the few more slides in the next few minutes. And this is other patient with Charcots in the left foot and the right side showing an ulcer. But we all think that this is a surgically managed, but it's not really actually, because the modern day practice that we should avoid an amputation at the max, that because nobody likes to have an amputated feet or a hand and go around. So this all from the OPDs over the last 10 years, 11 years since we started our foot clinic way back in 2009, I mean. So this is the various things we all see in our OPDs, and we think that this is just one another problem, but this is nothing but a diabetic foot. Diabetic foot doesn't mean that the patient has ulcer. It's always some callosity, fissures, and other even cons also included. So how do we go about as a medical physician, and whom to refer if required? That should be the answer you all should be having in your mind when I finish this. And this is another patient who has come to OPD few months back, and we all think that he already had an amputation. So when somebody has an amputation, there is almost 50 to 60% chance that there is one more amputation goes to happen in the next few years. There are studies to say that up to 5 years there is going to be one more amputation, and this amputation is not the way to go. It's about the conservation of or salvaging whatever part. So where is the worry? So the thing is, if you go back and flip the pages of literature, you can find that the amputation and ischemic diabetic foot amputation almost sits in between the cancers. So we all think that, okay, cancer is the major problem, but however, the amputations are much worse. If you take amputation alone, and in compared to if you take diabetes foot out, because of ischemia, it's actually enormous. It almost beats the pancreatic cancer over the, if you do an epidemiological study. So it is not a small disease, it's actually a major disease, but many often, and we tend to oversee in OPDs, and they all come back with a bad amputation. This is a rule of 15, where it is almost well proven, but we don't have a data from Indian population. But however, this holds good. Consider that most of the patients, I won't say patient, most of us have a barefoot walking. Barefoot walking doesn't mean that somebody walks outside their house barefoot walking. It's actually include a barefoot walking inside the house. And because of the cultural taboos and many other reasons, we tend to have a barefoot walking, which is as high as almost 95%. And if you look at yourself own, how many of you are go for a barefoot walking? I do still. So it's not uncommon. So it's very common. So, and the rule of 15, especially patients with diabetes, is that almost quarter of the patients with diabetes do get a foot ulcer over their lifetime. And remember that this all patient will have an, or most likely will have an future diabetic nephropathy or a retinopathy in addition, which may also hamper the other problem, lifestyle. And also remember that out of this quarter of the patient who has a diabetes foot ulcer, they tend to have an osteomyelitis, and out of which almost 15 to 20% had an amputation. So this is a simple rule of 15 or 50. 50 is that almost 50% will have this amputation, which is with transmetatarsal, or suppose even up to the below knee or above knee amputation. And it's all data from the West, and 50% do die of amputation over the years. This was a simple study which was done way back in almost 16 years back in an institute, and found that diabetic foot ulcer is not rare. It's actually a very common, and I just put the numbers to show that how the numbers are staggeringly high. So you can see here that this is another study which was done in based from Chennai, but the centers were across India, and they found that almost out of 1,300 patients, 1/3 had some degree of amputation, and out of which 3/4 was a minor, and rest of them had a major. So amputations is not very, very rare, but why do they get amputations? That is the main thing we need to remember, because the amputation almost always precede a small foot ulcer or a small callosity or a small fissure. So that is where, as a physicians, we need to pick it up early and prevention. So that is why the whole thing is about what is the real reason for all this, why a physician has to have an approach more to pick it up early, what kind of diabetic foot ulcer the patient have. So this is another epidemiological study from West, but it still holds good, because with the accounting barefoot walking. So though it is done in Western country, we are just going to convert into Indian rupees and find how much it is, just to show that how much is the cost involved in amputation and the subsequent. There are various guidelines. If you go to literature, there are a lot of guidelines across globe, and one of the recent guidelines is IWGDF. It's nothing but International Working Group for Diabetic Foot Recommendation 2020. It came in 2019. But published in 2020. So that was one of the guidelines which almost mentioned everything. But interestingly, if we look at almost all the guidelines, it's almost same. There is not much difference. But how do you evaluate a patient with diabetic foot ulcer? That's how. So we'll start up with a simple case scenario. This is a 56-year-old gentleman who had diabetes over the last 12 years, and they presented with 4-foot ulcer last 6 weeks. Remember that when the patient has a diabetic foot ulcer, never forget to evaluate for other complications, especially diabetic retinopathy as well as diabetic nephropathy. So almost always, all these patients will have some degree of nephropathy. It's not that they'll have a frank kidney disease, it may be just a microalbuminuria, other sites moderately increased albuminuria or minimally increased moderate. So you can say any word, but you have to evaluate for that. And also the retinopathy, one should not remember, forget that the retinopathy has to be evaluated, because many times it may be some other problem, because there was a patient recently we had where it was only 34-year-old with foot ulcer, and he turned out to be a multiple myeloma. That eye disease was not there, and he had a severe neuropathy, and he had an ulcer, and he was a policeman, and he had multiple myeloma. So the rule is that remember that any patient with diabetes uh, comes with an ulcer, it is not always because of diabetes. It can be another disease, but a simple, easy way to rule out is that check the eyes and check the kidneys, and look for other complications. So I already showed this patient's foot, and this you have a patient with a very well-defined ulcer. So many of us know that how to examine the sensation here. And one of the important thing is vibration and a monofilament. Um, Monofilament is nothing but a nylon filament, which is almost like the fish net nylon, where there are multiple um, weight for each of the gram. It's nothing but a weight, we call it because in grams, and it exerts a pressure of 2 gram or 4 gram or 10 gram. And if you see the guideline, why I'm talking about various gram is that if you see the guideline does not mention about 2 and 4 grams, but in Indian setting, we need to remember that all these patients should be examined from 2 gram to 4 gram to 10 gram, not as mentioned in the guidelines, where the guideline mentioned 10 gram. So it is important to find a sensory neuropathy at the earliest with a simple monofilament. You can identify that there is a sensory neuropathy. And if you look at literature, where do the monofilaments come is from actually the Hansen's disease, wherein Paul Brandt has done an extensive study on that. And monofilament is a very good tool to detect neuropathy. As well as second is simple vibration. You have a tuning fork, it's 128 hertz tuning fork. Simple is that just check it over the bony prominence, and many times they won't feel anything, because all this patient, because of the absent sensation, they tend to step over and sharp objects, and do all have a problem. So that's very, very important that you diagnose sensory neuropathy at the earliest in the outpatient setting, and prevent a foot ulcer like this. And you can see that this gentleman had an amputation already in the past, which itself is actually a route for another amputation, because this gentleman definitely has no sensation over the feet, and he stepped over actually a thorn. That's why he had a foot ulcer. So the prevention is very, very important than that. So when you look at the diabetic foot ulcer, I'm going to talk about how you are going to approach, because we are going to prevent it rather than treat it here. And if there is already had a foot ulcer, how are you going to manage as a physician, and whom you are going to refer to a surgeon for further treatment or a follow-up. So thing is, any patient with diabetic foot ulcer, you have to have a clear-cut approach. So this is going to be a abbreviation, that approach. What is approach is that any patient comes to you with diabetic foot ulcer, have a plan, keep with this approach in your mind, that all this patient age is very important, because as the age goes higher and higher, the patient tend to have a foot ulcer as their lifetime, because I already mentioned that up to 1/4 of the patient in their lifetime will have some degree of foot ulcer. It's not that a frank foot ulcer of 3 centimeter, 4 centimeter, it may be a 1 centimeter foot ulcer, or even 0.5 centimeter foot ulcer. That itself can be a root cause for an amputation in the future. And second is more that duration of diabetes. Previous foot ulcer, very, very important, because there are enough number of studies to show that the previous foot ulcer or an amputation, they can have one more amputation in the future. So any patient with the diabetes foot ulcer in the past and an amputation currently don't have a foot ulcer, remember that the patient is already in a hard seat that they may get one more foot ulcer. Renal disease, that is direct relation with renal disease with foot ulcer. And also remember that when the patient had a renal disease, when they get a foot ulcer, in fact, the renal disease worsens. There are Indian studies also to show that the renal disease worsen when the patient have a foot ulcer, though may not be having a infection underneath, they worsen, and when they get healed, though it don't go back to the baseline, but stays at a little higher level. And ocular disease, as I already mentioned, don't forget to check the fundus. And remember that affordability and awareness is very, very important, because when they come back to you, you're going to treat as well as prevent the future foot ulcer. So affordability makes a lot of difference. I'm going to show some video to say what are the various ways to prescribe a footwear so that the patient get an affordable footwear, as well as awareness very important, because that is directly related to the previous foot ulcer, that they should be aware that and educated that the foot ulcer can recur. Cigarette smoking is very, very important, because all this patient, you need to remember that whether it is a neuropathic ulcer or ischemic ulcer, because both the thing goes hand in hand many a times, and you have to take care of them. Ischemia part also, if you are not taking care of ischemia, the patient is going to come back with probably a peripheral arterial disease, and they may be having a gangrene and a subsequent amputation. Habit, barefoot walking, very, very important, and a HbA1c, because higher the HbA1c, prolonged diabetes, higher the age, high risk for foot ulcer. So we need to be smart. And how are we going to, as a physician, going to be smart? Remember that bone is very, very important. So if there is no bone involvement or bone involvement, the treatment differs. All the bone involvement doesn't mean that they have to go for an amputation. It's not the rule that somebody has an osteomyelitis, we have to, if there is an osteomyelitis in the greater toe, it has to be an amputation. It's not that. When the patient has a bone disease, that means osteomyelitis because of diabetic foot ulcer, they do not need a amputation always. There are indications, we'll come back to that a little later. Remember, skin is very important. Many patients, the skin has been neglected because a simple skin disease, nothing but a candidal infection in the web of the toe. That's very important, because an observation study in our institution itself found that those who come with a cellulitis to the medical ward or a surgical ward, if we examine the web of the toes, there is almost always had a candidal infection, which was the root cause for the cellulitis. So remember that examine the skin. Skin does not mean it's end with only skin, it's also nails. It's very important that nail may be dystrophied or fungal nails are very, very common in patients with diabetes, and it has to be taken care of, because most patients, what they do is, because of the dystrophic nail or a fungal nail, they tend to cut the nails deep, and they come back with cellulitis. So it has to be prevented. And as I already mentioned, monofilament is very, very important. And muscle. Why do you put muscle is, most of the time, the patient with diabetic foot ulcer won't have just a sensory neuropathy. They will all have a sensory and motor neuropathy. So, and cord test is written in all the book, but you just simple examination by looking at the feet, you can find that there can be a wasting of the muscle, clawing, hammer toe, mallet toe. We'll come to the picture a little later. And remember, simple examination, artery will give you an understanding whether it's a ischemic foot ulcer or a neuropathic foot ulcer, because that will have a different treatment aspect. Reflex, almost always, all this patient will have a absent reflex, because they don't have a sensation being passed on to their spinal cords. They'll all have their local receptors gone, so they don't have an ankle reflex, or if the patient has a severe disease, they may not have a knee reflex also. So tuning fork, in our setup, we have something called biesthesiometer. It's nothing but a quantification of the vibration. And tuning fork is just a qualitative check, whether yes or no. If you have a setup where if you have a biesthesiometer, it's nothing but quantification of how much vibration a patient do were able to perceive. So if it is more than 15 volts, we convert into the volts because it's a current which passes on and then it's converted into the energy and also vibration. So we just converted to volts. So if you have a 15 volts vibration, they can feel it is normal, and if they are more than that, that means there is some degree of neuropathy there already happened. So we'll come into the little case scenario so you understand better. So this is a lady who has come to me day before yesterday. In fact, interestingly, this lady came to us for a left foot ulcer, not for the right foot ulcer. I didn't show the left foot ulcer because it was a straightforward right foot ulcer referred to to another unit, and they referred to us, and the patient, that was absolutely normal, taken care of. But when we examine, as I already mentioned, don't forget to check the fissure and also the callosity. So when we look at the fissure, this looks absolutely a simple fissure with no connection underneath, looked very straightforward thing. So when we did an X-ray, you can see that I already told that any patient with foot ulcer, first thing is remember that do an X-ray, simple X-ray. Whether the patient had a probe test, because probe test is highly specific. Probe test is nothing but when you poke with the probe, if it hits the bone, that's a specific, but that may not be sensitive to when you do it as screening as an outpatient. So we did an X-ray. You can see that the terminal phalanx is totally chopped into two pieces. But if you go back and see, it doesn't look like an osteomyelitis at all. And this is how the patient with diabetic foot ulcer comes to us without having any symptom to suggest that an underlying bone involvement. Here the treatment is totally going to be a antibiotic for 6 to 8 weeks, just an amoxicillin acid. If the patient never had an antibiotic for this particular foot ulcer, and if there is a long history of somebody given from antibiotic in between, usually the gram-negative coverage will for 6 to 8 weeks will take care of this, and it generally closes, and usually the patient need to be offloaded. So I'll come into the little later what I mean by offloading with some videos as well as algorithm. So, but when you suspect osteomyelitis is ulcer more than just 6 weeks, you remember that yes, ulcer more than 6 weeks is just enough to show that there can be an underlying osteomyelitis. Remember this lady, the probe test was negative, but the patient had never complained of foot ulcer because she felt that it is in fissure. But when you probe her, she mentioned that it's there for more than 6 to 8 weeks. So that itself is enough to say that that could be an underlying osteomyelitis. Any foot ulcer more than 2 centimeters square, it's nothing but, so 2 centimeters square is nothing but a 2 centimeter foot ulcer. That means almost always check for osteomyelitis in every patient with foot ulcer you see in your OPD. That means almost always it will be there. If you take these two criteria, these all are highly specific. Recurrent ulcer, bone, CRP high, YASA, it's very sausage wound, local gigantism, all are highly specific. This is very, very specific, but this is, you just look at the numbers, 2 centimeters square size and ulcer more than 6 weeks. That means almost always you have to look for osteomyelitis, because that's where you give an antibiotic, not to all the patients with diabetic foot ulcer. So remember that this is one interesting patient I saw when I was doing my PG, and this lady was a staff nurse of our institute and of CMC. In fact, she is a retired staff, and she bumped again door. That's what she mentioned to us almost 9 weeks before she come to us, and we did an X-ray, and there was someone object, I would say object, well, because the bone is absolutely normal. When we remove the callosity, we found that there was a stone inside. So remember that a foreign object can also stay inside and have a patient may come back to sepsis and subsequently have a problem. So remember that if an unknown even sometimes in the past can also be there in patient with signs. So remember, so the next is skin. So I'll show some series of photographs to show that this also includes a diabetic foot ulcer. Diabetic foot ulcer doesn't mean that they all come back with a red and angry looking wound. It can be a simple callosity, fissure, an intertigo. All this also include diabetic foot. So that's the main area of focus for me here, that diabetic foot includes all these small things, because patient won't go to a surgeon to taken care of this. They all come to us because they have a uncontrolled blood glucose level, or they may be following up with this for their other ailments they have. So this is a callosity. You can see that this gentleman has bilateral callosity. See, callosity is nothing but there is an uneven pressure distribution across the toe, and there is one area of abnormal pressure. Most of the patient will have an anterior foot having a callosity or a fish, or got some ulcers. If you go and look back in your patient from onwards closely, you will always see a 70 to 90% of patient will have a forefoot ulcer, but it may be a little different in CMC because of the referral bias. So this is a callosity. If you don't take care of this callosity, you're going to be in problem, because the patient can come back with an osteomyelitis in the future. This is a gentleman. You can look at that. The patient has a callosity in the lateral malleolus as well as in the lateral aspect of the little toe. A simple history. This gentleman is a shopkeeper in the market, and he sits with crossed legs. Very common. And a simple history and a simple prevention. Just give a pillow, or tell them that put a small stool and sit over it, and you are going to prevent a foot ulcer in the future. So a simple history saying that what's your work pattern is going to have a greater impact. You're going to prevent a foot ulcer, maybe an amputation in the future also. Can you see that this lady has fissure here? And if you closely look, there is a bunion. Bunion is nothing but there is a hallux valgus with a callosity here, and you can see there is a crossing of the foot, the toe from between first and the second toe. That means the great toe and the second toe. So there is a crossing. So when you walk, it's going to be like this. So they will have a friction like this, and they will develop ulcer. A simple footwear modification, I'll come into that with videos, can have a greater impact in the prevention of foot ulcer, because that is what all about. Diabetic foot ulcer is all about prevention of future foot ulcer and prevention of amputation. So this patient, if you give a toe separator is nothing but a simple small, I'll show in a video, and how to what is exactly is that. So we'll go to the little video session on it, and I just a minute, can you just play the video? So that will give an idea what exactly I'm talking about. I stopped. This one?
I'll do it from there.
Oh, you do it from there?
This prevents any kind of foreign objects or foreign materials which can pierce and enter through it. The insole is made up of microcellular rubber where the pressure is distributed evenly. It has got a back strap to compensate for intrinsic muscle strength paralysis, and it has got an adjustable front strap. This is made up of Velcro material. This will compensate for any kind of dressings or neuropathic edema. The insole is made up of microcellular rubber where the pressure is distributed evenly. It has got a back strap to compensate for intrinsic muscle strength paralysis, and it has got an adjustable front strap. This is made up of Velcro material. This will compensate for any kind of dressings or neuropathic edema. we usually check the
So
rubber
remember that this is a foot ulcer.
by using
You
an
have to prevent it
instrument
in the
called as the
future. So
durometer.
what is an ideal
The
footwear? The
durometer is
ideal
placed on
footwear
the
is that
insole of the footwear.
footwear should be
Once this is
not
placed,
soft,
this is measured
not
in shore value
hard. So
8.
what
An
we
ideal
use
footwear should
something
give a
called a
value
durometer,
between 8 to
which to see that
15.
it's not soft
Lesser
or
than
it's
8
hard. So
means
you need to
the
maintain a
insole is very soft,
softness on
where
the
this
this
can
or
cause
otherwise
some kind
hardness
of
of the
problems to the
footwear.
patient when
So
they
this is a
walk.
footwear
The harder
which
it is,
has a
patient
shore
has
value
more
between
chances of
8 to
developing
15
higher
because this
pressures,
is
and
a
thereby
range
they can
where
develop
the
velocities.
footwear is not very
What exactly do you mean by the term offloading?
very
Yeah, so
soft
The
or the footwear is not
is
very hard,
placed.
so that
This
you
is
can prevent
measured
a
in
footwear. So it is
shore
an MCR
value
footwear.
8.
It's nothing
An
but
ideal
a
footwear should give a
microcellular
value
rubber, which
between
is
8
nothing
to
but a
15.
rubber mixed with
Lesser than 8
lot
means
of air
the
bubbles
insole is very
in that,
soft,
so
where
that it
this can
actually
cause
has
some
a
kind of problems
good
to the patient when they walk. The harder it is,
compression, so
patient has
that
more
they
chances of
can
developing
recoil it
higher
back to
pressures,
their
and
old
thereby
shape. So that is
amputation in the
how
past,
it's important.
and
So
this
remember
means that
that this is a
patient
very
is
common
having high risk, and if this is an anterior
we've seen
or a
foot
forefoot
ulcer in the
ulcer, and
OPD.
this
You can
gentleman
see
was
this is
given
a
an footwear in the past
this is
where
a
you can
patient
see
with
that it's a
anterior
worn-out
foot
footwear,
ulcer,
and
and
also
almost
footwear he was
always you have to
given for
remember
the
that
other
examine not
level.
only
You
the
can see
foot,
this is a worn-out
also
footwear,
remember
wherein
that we examine
he was
the
given
footwear
anterior
also. You
wedge
can see
which
this
has been come
gentleman
off from
now.
the
He
inner
didn't want
sole.
to come back to
So
us and
this
say
is a
that my footwear
typical
is
worn-out
worn
footwear,
out.
and this is the
So there can be a
footwear which he
phoning
was
between the patient
prescribed,
and us that
which
we
is
need
a
to find
replica
out
of the
whether the
footwear where
footwear
you can
is worn
see
out. This
there
is a
is
footwear we actually
wedge in
prescribe
the
to the patient.
anterior part, and
So,
so it's
but can
called
you see that the
anterior
footwear is
wedge.
actually
This anterior wedge
worn out?
should be
So we
prescribed
have
to a
to
patient if the
make
patient
sure
has
that
a
footwear is
forefoot ulcer,
also good
or in
when
other
you
words, an anterior
actually
foot ulcer. If you see
examine the
that
patient. Otherwise,
once it heals,
the
the
patient
patient has
footwear
to
is
be
this, and this is
prevented,
the
should be
footwear
advocated so that
supposed to
the
be.
ulcer
Okay, it's
does
almost
not
a replica of
recur
that.
again. So in those setting, you need to give what is called an anterior rocker, which may not be similar to a wedge. You can see the wedge is there is more.
Okay, so that's very important. Can you? So in fact, the gentleman I showed in the picture, in the video, had actually a ulcer, callosity in that actually, and we removed the callosity and there was a foot ulcer underneath. So most of the patients, when they have a callosity, they will have a small or maybe a large foot ulcer like what that patient had. Yeah. So sorry about there was a technical problem that its screen was not shown. So these are the various ways a patient with diabetes can present, where they can have a bunion with a hallux valgus. Then after a few days, the patient may come back with a foot ulcer in the bunion, or maybe because there was a crossing of the footwear, toes, they can have one foot ulcer in the dorsum of the foot, and finally they may end up with an amputation. So all this can be a cause for an amputation in the future. So skin and also the intertigo is very important. This lady, when she came to us, she already developed a small cellulitis and a bit of a gangrene because she had an underlying peripheral artery disease also. So this is a simple thing, because this patient might have had a fissures initially, might not have noticed, and come back with a foot ulcer in the due course. Okay, so we need to have a proper plan if the patient come back to a foot ulcer. The plan is that, as I already mentioned, always rule out an osteomyelitis. the location is very, very important, because the location gives us an idea what the footwear we are going to advocate in a patient, and the appearance. Because if you go and read out the guidelines, and it is, I would say that recent guidelines, in a patient with diabetic foot ulcer, you always give a total contact cast, invariably all the patient. So, but that is not feasible in our Indian subcontinent, where patient may not like to wear a cast. So, and also remember that nature of footwear, as I told, that what the patient already wearing is also very, very important, because if we examine, that's very, very going to give a clue the patient is having a worn out footwear, or and this going to decide what kind of offloading we are going to have. Before that, apply your plan. Remember that there is no underlying infection. We all know that simple way of looking at infection is local warmth, temperature, increase in the redness, all will give a clue. But one should not forget that ischemia is a very, very important part, because ischemia will change the diabetes management, because we need to refer those patients to surgeon, or if possible a vascular surgeon, to look at what exactly the cause for the ischemia. So that's where a physician and the surgeon liaising together, it's going to come, but the patient is not going to tell us that I have a ischemia or I have a neuropathy alone. So a simple peripheral pulse examination will most of it will give whether the patient has diabetic foot ulcer due to neuropathy or ischemia or neuroischemia. So a simple examination, dry skin, a fissure, a simple examination of pulse will give an idea where you are dealing with, because the amputation rates are little higher if they have both. And most of the patients with diabetes can have associated ischemia, even though they may not be smoking also. So that is why a simple examination is going to help us where we are going to take it further, because I already mentioned something called offloading. Because all this patient, when you are diagnosing a foot ulcer, if you don't offload it properly, they are going to come back again and again to the clinic and may end up with an amputation. So remember that before stepping into an offloading, keep in mind that if the patient has a swelling, induration, temperature, and erythema or a purulent secretion, that means all this patient has an infected foot ulcer. That means we definitely have to refer to a surgeon or a vascular surgeon, depending upon the place where you work, so that they are taken care of, because they may need a surgery to have their life saved, or they may end up in amputation, whatever, maybe having an underlying necrotizing fasciitis where they need a fasciotomy or whatever. So remember that a physician role is to liaise with the surgeon, but before that we need to know the ulcer is infected. As I mentioned, that all the foot ulcer, if they come to you, even if it is small, doesn't mean that they are infected and need an antibiotic. The antibiotic will come into the picture when you actually have this signs and symptoms. All this, simple terms you can remember this ST square step. So so this is a gentleman. You can see the amputation. We will apply the rule what we had. So the patient had diabetic foot ulcer. This was a 56-year-old gentleman who had a long-standing diabetes, had an renal dysfunction in the past with the current creatinine of 1.5, and has a foot ulcer. You do an X-ray foot to make sure that there is no osteomyelitis, there is no infection. You can see there is not much of induration surrounding. The nails were dystrophic. This gentleman, though they do have a thing. You remember that once you rule out there is no infection, you have to remember that you have to offload this out of the ground. It is a simple theory that if I or you have an injury in this hand and it is in the dorsum of the hand, we will never allow somebody to touch it, or we will take care of such a way that nothing hit this or touch this, so that the wound healing is appropriate and fast. That is a simple way of explaining and offloading. Remember this, all this patient had a foot ulcer. Whatever I'm talking is not in the dorsum of the foot, it is in the plantar aspect. So that means the whole body is actually having pressure in the plantar aspect. So if you don't offload it properly, they are going to come back with some ulcer in the future, or they may not have a proper healing of foot ulcer. I won't talk about an antibiotic of debridement because it will deviate the talk, but I will just go some couple of slides on why, where antibiotic and why. So in it, I already mentioned that all the patients, whether they come with a small or a big ulcer, do X-ray first and make sure that you rule out an osteomyelitis. Osteomyelitis, even if they don't have an infection surrounding, you have to treat it because the bone is already infected, and for a good penetration of the bone with an antibiotic, you tend to give 6 to 8 weeks of antibiotic and take it further. These are the simple way to understand that maybe a chip of the bone out, but remember that that can be a foreign body or a calcified arteries or soft tissue gas, which many times will mimic osteomyelitis, as I already shown that the lady with small stone inside the near the bone, which mimic like an osteomyelitis, but it's not an osteomyelitis. But one of the problem with X-rays, many times this patient have a little overlap between the Charcot's foot. So I'll show one video of the Charcot's foot and what exactly is this, what is Charcot's foot and what are the ways to look into that and take it further. So, so it can have a little overlap, but however, many centers, especially the mission hospitals and peripheral centers, the MRI may not be possible. So a presumptive diagnosis of osteomyelitis should be done and taken care of. A little couple of debridement, because we generally don't do debridement and dressing in our outpatient, but we have a foot clinic where we do so. But it's a simple rule is that we have this thing in mind at time. Make sure that the tissue is debride properly, the infection is controlled, moisture is balanced, and epithelial edge are advanced. So these are the simple things we look at, and just for your understanding, the ideal dressing should have some certain characteristics. Also, what we choose is, if there is dry, we make it hydrated. If there is too much of drainage, we make it to little less. And if there is necrotic, this is a rule of thumb. There is nothing we do extra, and there are a lot of argument between saline dressing and advanced dressing. I won't go into that because it's out of the discussion. But remember that what I'm going to really focus is on offloading. So before offloading, I'll just show a video of, can you open that video? Or I'll show it from here. I stopped sharing. So video to show what exactly the Zoom. Okay, yeah. Share screen. This one. No, this is my video. I open. Okay, I'll do it from there.
Guidelines
I'll try to
mentions
show
that the patient has to be given a total contact cast or a knee level cast for the complete offloading. But how?
Just give us a second. We'll just try to share it from another computer. Yeah. Can you give an access for this? Okay. I got an access. Okay. So there are various ways to offload a patient with diabetes with an anterior foot ulcer, because I won't talk about a posterior foot ulcer or a mid-foot ulcer, because we'll come to the algorithm in the next slide. When a patient comes to you with an anterior foot ulcer or a forefoot ulcer without any infection or an osteomyelitis, or if for that matter maybe an osteomyelitis also, there are various ways to control the control the foot from touching the ground. So I'll take it from from a prospect of what is available to what if you don't have a setup where you don't have anything. So you can see that this is called nothing but a wedge. It's called a wedge. This can be done in our setting. This is called a rocker. There is a difference between rocker and a wedge. If a patient comes with an active foot ulcer, we give a wedge because you can see there is an offloading kind of one in the anterior foot. And once the patient has a healing of foot ulcer, subsequently you can give a rocker. So there is a difference between rocker and a wedge. And suppose you are going to set up where you don't have an anterior rocker, because anterior rocker needs a little more sophisticated orthotic department to do. So if you don't have that, the simple way of doing is just put a bar. But remember that don't put the metatarsal bar within that. Keep the metatarsal bar outside, because always this patient will have some other problem like clawing or mallet toe or hammer toe. So it tend to have a problem in the future, because that can precipitate one more foot ulcer in the tip of the toes. So just keep the bar outside. It behaves like an anterior rocker or a pseudo rocker, very easy. And this is not because this physician has to do. We have a PMR setup where we have all the discussion been made between them, and we do this. But if you go to a setup where you may not be having a full podiatric setup, you have to remember that this a simple technique to make them offload it. So that is and the other one is, if you look at, if you say that you don't have a metatarsal bar also, this is a old teaching that if the foot ulcer is very small, just scoop it out in that sole, so that you little void there that can like an offloading. But this is not a very great thing, but if you don't have anything, you can simply remove that. And this is a very old school of thought that when the patient has a bigger foot ulcer, and if you really want to make use of your whatever available resources, put a little plank of a wood in between and chop it off in the area where there is foot ulcer. And it is very durable foot wear. You remember that this is one of the durable footwear you can ever get, is because you are getting a plywood or a wood in between. But the problem with this is it's going to be very, very heavy, so the patient may not able to walk around. So that's very important. So I'll show that, as I told already, that there is something called toe separator. I showed when the patient has a crossing of toes, I mentioned that you can separate the toes with a small device where it's called a toe separator. It's available in our pharmacy, it's in our orthotics, as well as in the outside. Even Amazon is selling this in their online shopping. So you can see this gentleman has a crossing of toes. It looks a little small, but however, you remember that this rubs it, a friction, heat is generated, and the patient won't have the feel of the increased warmth or increased friction because of that temperature is raised. They won't feel it. And you just a simple toe separator and just a socks. And this gentleman also has a claw toe here. Just put a toe cap, simple. And I'm sure this gentleman is not going to go into a surgeon and say, I have a claw toe, I have a cross it, or so they won't say. So very important is that remember that a simple foot examination, that gentleman don't have foot ulcer, you can actually prevent a foot ulcer. So this is another gentleman. You can see this gentleman has Charcots, very classical Charcots feet with bilateral Charcot with bad foot ulcer in the mid part. So it's going to be really challenging. And yeah. So when a patient with Charcots come to you, you need to remember that one of the things you need to remember there is what is the degree of Charcots foot. Charcots foot is nothing but you would have heard in Charcots in tabes dorsalis, a non-diabetic disease, and also in patient with sphringomelia, so many other conditions. But remember that this Charcot's joints, once they get, that means they are almost towards the end of some degree of irreversible. So what we do is, when the patient comes with a Charcot's with even without foot ulcer, you have to prevent a future foot ulcer. So how do you tackle it? Just a foot X-ray will show that.
Rajesh was rumors. And I was like, you're horrible. No, it's more than what meets the eye. Oh, definitely.
Yeah. So when you do a simple X-ray, so you need to remember that when you do a simple X-ray, that means you need to put the whole weight, so that you understand that that whole weight is exerting on the ankle joint, in the other small joints in the toe, in the foot. So here this gentleman had a standing lateral. So the best X-ray you can do is a standing lateral. There you can see this. Remember that all this patient will have some space in between, or normal foot will have some space between the joint. Here you can see this is totally collapsed, and this is dislocated, and this is posterior. So we have types depending upon that, what exactly the Charcot's type is, and this is an end stage diabetic neuropathy and its complication. You may not always see, but remember that when the foot is when the foot has become a rocker bottom, only they'll all have this problem, unless that you won't be able to see in the clinical setting. So once a patient has a rocker bottom foot, that means you can see in this gentleman had all the arches been lost, and the patient is not going to complain unless has a foot ulcer. So you have to examine and put a proper X-ray. The simple X-ray standing lateral will give an idea what exactly the degree of the arches are. The arches are collapsed. That means the patient has a stage 3 Charcot's, especially in the tarsal bones. And when they have a subtalar joint, the subtalar joint is dislocated. That means it's type 4. And when there is posterior displacement, that is type 5. Most of the patients, when they have this type 3 and type 4, they invariably have a type 5. That means they have an unstable ankle joint. So I'll go back to the other.
That is the implication that the callosity has to be removed in all patients with diabetes foot ulcer. And also had to be mentioned that this gentleman has
can you see?
Clotos, and this can be a problem in future, because
remember that the offloading
can
is
develop
a must in terms of patient with
which
diabetes
could be
foot
a
ulcer,
detrimental
as well as
also.
prevention
So
of foot
in
ulcer.
this
It's not
kind
that
of
offloading
problem
means
you
need
can
to give
use
in patient with
something called
foot ulcer
a
alone.
toe cap,
You have to give
wherein
in patient
you just
with
need
without
to
foot ulcer, because
put
if they
over
had
the
already
toes,
past history, you have
so
to
that
continue that such a way that
it may not be
it is
called an
continue to be
offloading,
used
but
for at least for some
definitely
time
it helps
or
in prevention
indefinitely
of a
to prevent a foot ulcer.
So
this is a simple
I would call this an
algorithm.
offloading technique. Toe is
I won't talk about the
straightened and
amputation,
cushioning effect
but
in the tip of the
remember
toes.
that you can
And
get a
also
patient
in
with amputation,
some of
but
the patients,
I'm trying to
you can see already in this
explain, I'll
patient
try to
there is
explain
a
on ulcer and
crossing
the
of the
Charcot's.
toes
So when the
between
patient comes
the
with ulcer, doesn't mean that large
fourth
ulcer,
and
even a
the fifth
0.5
toe.
or
So
1
in
centimeter
this
foot
kind
ulcer,
of a
split it
problem,
into 3
you
halves,
can use
for
something
your
called
easy understanding,
toe
4 foot, mid
separator.
foot and high foot.
We
The patient
just
has a 4 foot ulcer,
fix here,
very easy, because 80 to 90%
and you
of
can
patients,
prevent a
if they have
foot
a
ulcer,
fissure or a patient
so
with
that
having
there
an
is
anterior
no
foot
friction
ulcer,
between the
just to remember
toes.
that an
And
MCR footwear
so a
with
simple
an anterior rocker, if you write that MCR
toe
foot
cap
anterior rocker,
and a
they
toe
will
separator
definitely
can
our
help
orthotics,
in the prevention of
people
foot
will,
ulcer
give it.
in this
And
patient
you have simple
with
footwear with a
clawing
slight
or
modification will take care of
a
that.
crossing of
High
the
foot and
toes.
So let's
mid
go on
foot
to
ulcer
our
not
third
common.
patient. This is a gentleman with
In books it's
classical
written that,
Charcot's
or even in
arthropathy.
guidelines, you just
Take a
give
look
a
at the
total
foot.
contact
You
pass.
can see
But a
loss of
simple
the
word
arch,
like mid-foot
a deep ulcer
orthosis,
over
it's
here.
like a
And
anterior rocker, you are
if you
just
look
putting
at
some
the medial
orthosis
aspect,
in the
you can see
mid-foot
that
or a
there's
hind
loss
foot.
of the
will
arch
give an idea,
and prominence
will
and
give
the
a, will
edema
prevent
over
a
here medially
future foot
as well as
ulcer.
laterally.
And I won't talk
Over
about the
to
amputation,
Felix,
but
who will tell
there
us
are two
more about
patients
this
who had a
aspect.
past history of
So this
amputation. They
gentleman
come
came
to
to
us,
us in
and those guys
2019
also need to give a proper
wherein he
footwear,
had
because proper footwear should
clinical
come
features
from a physician
codes, and
to,
we
so that
took
it
an
will be
X-ray
prevented.
during that time,
We cannot
and
always
you
search
can
for
see
a
this
physical
gentleman
medicine
has
rehabilitation
loss of
physiatrist to prescribe.
arches of
It's
foot,
our job.
and
And when it
also
comes to
had
Charcots, remember that it's a stable or unstable. What
the
is stable is
subtalar
if the ankle joint is involved, that
dislocated,
means if
and also displacement of
if the
that
subtalar joint or
posterior
ankle, it's
displacement
nothing
of
but
the
an ankle joint is
calcaneum.
involved. That is called
Can
unstable.
see here,
If
and so
if
this
the
accounts for stage 3,
that is involved.
4,
That means
and
type
5
4
Charcot's
or type 5 it is
arthropathy.
not there, or
When a
in other
patient
words,
has
only
Charcot
type
foot
3 or
disability,
without
we
any
need to
subtalar
check
joint
whether the
involvement.
patient's
You have to
ankle
give a
joint
molded
is stable
insole.
or unstable.
So molded insole is
If the
nothing
ankle
but
joint is
give
unstable, we
according
need
to
to
the foot
immobilize the foot and
shape.
the ankle
That's
together.
the,
So we
they
give
will mold
appliances
a
called as
footwear.
ankle
That
foot
means the
orthosis
inner
or
part
ankle
is,
fixed
that
orthosis,
means the sole, inner
whereby
sole
the
is
ankle joint
made in
stability
such
is
a way that
totally
there will be a
maintained, and we are also
dip and a bump
immobilizing
and
the foot
everything
of the
according to the
patient.
foot,
The
so that
outer
it will
material is
maintain
made
the
up of
pressure equally,
plastozet,
but it may
so
not
that this is
always.
very rigid. The inner material is made up of EVA material, which is called as ethyl vinyl acetate, so that this forms a very cushioning material for the patient, and it doesn't cause any kind of
Maybe another computer. Okay, maybe another computer. So it's in another computer. That computer is running. So so that's very very important, that where what kind of Charcots is, you may not see always, because this, it doesn't mean that this all patients would have a foot ulcer. If they don't have foot ulcer, you have to press. So what you commonly see is a 4-foot ulcer or a past history of 4-foot ulcer. That's what you will see a lot of patients. So if they have a foot ulcer or don't have a foot ulcer, or even a small intertigo or a cross toes or a clawing or a mallet toe, hammer toe, you can actually no. It's muted. So you will see commonly this 4-foot ulcer or 4-foot past history of foot ulcer, a simple MCR with an anterior echo will serve the purpose. Though it may not prevent all the foot ulcer, or it may not heal all the foot ulcer, because that certain patients do require other modalities. But in general practice, this is the commonest, and MCR with anterior rocker. So remember that from now on, with any patient with a clawing or a hammer toe or a mallet toe or a crossing of the finger, crossing of the toes or a bunion, you can simply prescribe an anterior rocker, MCR, and get away with that. Midfoot and hindfoot orthosis needs some degree of an expertise in terms of offloading as well as prevention, but it is not common. But if they have that, remember that if you're working in a place where you don't have an accessory setup, simple way of doing is a TCC needs an expertise help, but definitely can be done in most of the other centers also. Charcots, they may not come to you with a foot ulcer. They may come as a regular patient when the foot is altered, shape is altered. That means they have an underlying Charcots. And remember that this has to be divided as stable or unstable. And if there is a stable, simply you can just write MCR with a molded insole. They prescribe that will prevent a foot ulcer. And unstable Charcots need an expert help. But remember that unstable Charcots can have a bad foot ulcer, made an amputation also. So an AFO, what is AFO is nothing but an ankle foot orthosis. Ankle foot orthosis is nothing but to stabilize the ankle joint. So this all may be new term, but ankle foot orthosis will prevent a future foot ulcer and an amputation. But there are a lot of newer modalities like pneumatic footwear, air cast boot, all have been available for this. This may be a minor number, but remember that this can be seen in, and you can refer to a center where there is a facility to provide. But remember that unstable chakra doesn't mean that all the patient will end up in a amputation. So any patient with, so whatever I discuss, I'll put it in a one slide and understand that diabetic foot ulcer doesn't mean that it's almost always a foot ulcer. It means that a callosity, fissure, clawing, malatoes, hamatose, bunion, all are nothing but a diabetic foot only. It may not be having an ulcer, it's a diabetic foot and a risk for diabetic foot ulcer. Higher the age, longitude of long duration of diabetes, a past history of foot ulcer, a barefoot walking, all patient might have had a foot ulcer and healed. You have to check it for it, because those are the guys we need to remember. We need to prevent a foot ulcer. Remember, be smart and make sure that the bone is involved or not. If a simple X-ray foot will give an idea whether the patient has a osteomyelitis or not. If they have an osteomyelitis without an infection itself, you have to give an antibiotic. Otherwise, it's not required. Once you have an foot ulcer, you need to remember in mind, you have to offload it. Antibiotics, yes or no, depending upon the osteomyelitis or an underlying skin infection or cellulitis, and you have to refer to a surgeon. And also remember that offloading is very, very important once the infection is settled, and long-term follow is very, very important, because all these guys come back with a foot ulcer, and also education is important. So remember that the idea is that prevention with a proper footwear, most of your patient will have an anterior problem, that means a forefoot problem. The simple MCR with an anterior rocker will serve almost all the purpose in your patient, and minor maybe a midfoot and hindfoot, and Charcot's is a minor which needs expert. So this is a remember that this is a small ulcer. When you debride it, it's sort of big ulcer. When you debride further, it actually a major foot ulcer. So we put a TCC. This is nothing but a TCC with a polar iron. You can see within 2 months it got healed. So this is how the healing process is actually goes on. This is another gentleman with a bad foot ulcer. We just put a TCC. I said certain group of patients, the anterior rocker won't work once the foot ulcer is more than 2 to 3 centimeter. The TCC was applied by PMR physicians, and you can see within 3 months it actually healed, because in between the patient lost the follow-up and it was reapplied, and you can see that within 3 months it healed. So remember that a simple footwear, that's it. A simple footwear, I would say that anterior rocker with an MCR with an anterior rocker will solve almost all your patients if they have clawing or whatever things in the toes. If they have a normal feet without any clawing, a simple MCR, universal MCR in all your patients will prevent a foot ulcer. So if there is any doubts, you can always welcome to ask and clear. And prevention is very, very important than treating. Okay, somebody asked a question, toe separator. So toe separator is nothing but a small silicon made device. If you put it in the Amazon itself, you will get it. So you just need to put it in between the toes, and this will separate the toes, because the cross toes can be separated with the toe separator simply like with the socks, because this will get displaced if you not put a socks. So toe separator is a silicon device between that to prevent a foot ulcer.
Felix Jebasingh.
So any other doubts? Any other doubts?
There's one more question. How long should we use toe separator?
See, the toe separator is a long term, because if you speak to your physiatrist or speak to an podiatrist, they say that you can do this is I didn't cover it, but that's what I said. Certain things are maybe little out of the box, may not be for this topic, So what we put is just, they say that just cut which is overacting. Suppose the patient is having a plateau, that means there is a flexion. So this is overacting, the muscle underneath is alright, so cut this, so it will get straight. But that will not serve the purpose. So the toe separators, if there is a cross toe, that means there is intraosteal or lumbricals is overacting. So it is actually crossing is because of that. So you cannot cut the muscle or you cannot cut the tendon. So the toe separator has to be a long-term, like you have to do indefinitely, because this all are end-stage problem. This is not a starting of some problem, it's an end-stage problem, so you have to treat with it. So how do you treat the fissures? If there is no underlying infection, there is no underlying problem, a 6% salicylic acid, if the patient has a very thick callosity, you can use 12% salicylic acid. Salicylic acid, it will cure. If there is a setup where you can use a pumice stone, which it's an old school of thought, but however the pumice stone is very good thing to rub over it. It will also be behave like a 6% salicylic acid in the mechanism, and it's nothing but you are trying to close the fissure with 6% or 12% salicylic acid, depending upon the thickness, or even a pumice stone, which now is actually available in the market. I'm not sure how the pumice stone available in the market is authentic, but authentic, if you have a set where you can get the good pumice stone, it also serves the purpose, because I've seen most of the shops now have pumice stone, but I'm not comfortable with that because 10 days are not the real pumice stones. That's it. Any other questions?
James, change in footwear, advice to the patient.
Yeah, so good. I mean, if the patient, this is the toughest thing in the real life practice. All this MCR footwear, when they use inside the house as well as the house, because remember that all this patient, when you are teaching them, they ask them to buy in footwear for an outside the house as well as inside the house. That's very important, because they should have two separate footwear has to be outweight, and the durability of the footwear is somewhere between ranges between 6 to 9 months. We don't have a real data to tell us, but maybe after 6 to 9 months we may be able to tell how durable it is. But if the patient regularly uses it, somewhere between 6 to 9 months, but most of the patient will have a 6 months durable, because as the patient wears continuously, it gets worn off faster. So 6 months to 9 months. There is nothing government involved in this in terms of footwear, because maybe we need to sensitize the Tamil Nadu government to give free footwears like free cycles or something, but we don't have right now a program to really deal giving footwear for all of our population. But it's a good thought. Thank you for that question. It stimulated me to think something.
Any further questions? I think that was a very clinically oriented, detailed, and very significant lecture on approach to diabetes, something that we very often see now. OPD, medicine OPDs. Knows it, often forgets to see it, and often doesn't know what to do about it. So I think that was a very relevant topic and discussion on that. Thanks a lot for that. And I think if any further questions, please approach sir in person. This lecture will be uploaded soon in the Department of Medicine YouTube website. I think we'll wind up now, sir.
Yeah. And if there is no further questions, I think that's fine.
Thanks everyone. We'll close the meeting.
Yeah, thank you for the questions. Thank you.
Reservation 5 months. Usually